So without any further delay, we will move to our first lecture, which is being given by Professor Edgar Peters, who is an associate professor from the Netherlands and is going to tell us about the international guidelines on diabetic foot infections and update.
Good morning, ladies and gentlemen. Thank you very much for the organising committee to invite me to speak here. If you could please bring up my first slide, please. My name is Edgar Peters, and I work as an internist and infectious disease specialist and acute medicine specialist in Amsterdam. And I will be talking to you about the international guidelines on diabetic foot infection. I'll give you an update. I have some disclosures. I am a member of the guideline committee that develops guidelines for diabetic foot infections of the International Working Group Diabetic Foot. And I have been a member of the Infectious Disease Society of America and Dutch guideline committee that did the same thing. And I've received some non-pharma, non-commercial research funding. And my main disclosure is that I work in Amsterdam, at Amsterdam UMC, location for UMC. As you can see here, the patients are very anxious and lining up to see us at the hospital at the Diabetic Foot Clinic. My take-home messages and my goals will be of this talk is that infection is a clinical diagnosis, and that if you want to prescribe empiric antibiotic treatment for diabetic foot infections, you should know your local resistance profile. In case of mild infection, you can treat Staph aureus and cocci for empiric antibiotic regimes, and in case of moderate to severe infection, it's wise to include gram-negative organisms. I've already mentioned the International Working Group on the Diabetic Foot, and the International Working Group Diabetic Foot has published guidelines that were presented in 2019 at the ISDF in The Hague. And the guideline committee consisted of several specialists in the diabetic foot, chaired by Benjamin Lipsky, and Eric Sandville and myself were the secretaries of the group. As you can see, most of the group members were from, all of the group members were from several parts of the world, and they were from different specialties: surgeons, infectious disease specialists, microbiologists, endocrinologists. That group has published guidelines on both the diagnosis and treatment of foot infections. And I will focus in this talk on the antimicrobial treatment of diabetic foot infections. I could talk on for hours about surgical therapy, diagnosis, etc. But, well, we have to focus. This is a picture of the group. We can see the surgeons in the back sitting cozy together, Dr. Argan Sanchez and Professor Lavery, and the other members of the group. This was a picture taken at Heathrow Airport in a hotel. And as you can see, at the same time, there was another society studying their guidelines just as religiously as we did. And what we did is that we reviewed 15,000 titles for therapy on the diabetic foot. And we included 53 studies that had a contemporaneous control group. 25 of those was to systemic antibiotics. 11 of those included subjects with osteomyelitis. There was one cohort that looked at bone biopsy culture-directed therapy versus swab culture-directed therapy, and 5 to surgical interventions. One of them was an RCT. In general, we found that there were no differences among antibiotic regimes, except that ticacycline did not do as well as ertapenem and had more side effects and more serious side effects. And I put that in between brackets because I'm not really convinced that it was relevant. Ertapenem in one sub-study in a subgroup of patients with severe infections did not seem to do as well as piperacillin and tazobactam. The healing percentages were, as you would expect, somewhere between 50 to 90%. And if you included patients with osteomyelitis, it was also 61 to 94%. I'd like to highlight two of the trials that were looked at. One of them is an RCT of surgery versus antibiotic treatment that was in patients that did not require immediate surgery, that had forefoot osteomyelitis. Now, the reasons for surgery could be that somebody had an abscess or a necrotizing infection or protruding bone or something like that. So these patients did not have any of those things. And the results, the Spanish authors did not find a significant difference between the two groups. Another study was a French study that looked at the duration of conservative treatment in roughly the same kind of population, so the patients that did not require immediate surgery. And they looked at a 6 weeks versus 12 weeks duration of antibiotic treatment. And they also found no significant difference between the two groups. Now, that being said, I'd like to stress that it's in a subset of patients that do not require immediate surgery. But perhaps it's possible that we prescribe antibiotics for less than 2 weeks. A more recent study has been published about half a year ago, a Swiss study that looked at 3 weeks versus 6 weeks of antibiotic therapy for diabetic foot osteomyelitis. They allowed some debridement of necrotic tissue. They prescribed randomized patients into 6 or 3 weeks of treatment. It was designed as a non-inferiority randomized controlled trial in 93 patients, and the median number of surgical debridements in group was 1, ranging from 0 to 2. And the results were in the intention to treat analysis that after 3 weeks, 84% was in remission. 84% was in remission in the 3-week antibiotics group, and in the 6 weeks group, 73% was in remission, which was not statistically significant as a difference. The amount of adverse events were approximately similar in both groups. So that probably means that we still treat patients with antibiotics for too long. But we need more studies to get a definite answer, because the last study was still a pilot study in a non-inferiority design. So how do we select an antibiotic? Well, first of all, you have to consider if what the likely or proven pathogen is and its susceptibility. Now, to do that, you have to look at, well, your own local circumstances, and you have to look at differences among countries. For instance, there are differences between being from the Netherlands, like myself, and being from the UK. For instance, the Dutch apparently consume 3.1 times more oil than people from the UK. And I can assure you that's not oral intake of oil, but that has probably to do with Rotterdam being a very important harbor and an important hub for Germany, Belgium, and the rest of continental Europe for import of oil. Interesting is also that the Dutch are approximately 20% more likely to be unemployed. And I would say as a consequence, they have more free time. If you look one row down, that while having more free time, they seem to make more money in their free time. Interesting. But the most important reason that I show you this slide is that the Dutch apparently spend about 60% more money on healthcare. Well, that means that the healthcare systems are different between the Netherlands and the UK, and probably also other things. For instance, if you look at MRSA prevalence in Europe, a slide from the European Centre for Disease Control, you can see that in Southern Europe, there's a lot more MRSA than in Northern Europe. And you can also see on the left bottom graph that the amount of MRSA is drastically reduced in the last 2 decades in the UK as well. The same is, and that's the Netherlands, by the way, so your eastern neighbor. The same is true for Klebsiella pneumoniae and carbapenem resistance. Very low in Northern Europe, including the UK, but there's a lot of carbapenem resistance in Southern Europe. Well, this is a slide that compares the amount of antimicrobial resistance. Here on the left side, the antimicrobial resistance for Klebsiella, carbapenem resistance, and on the right side, almost the same picture, the amount of alcohol consumption. You can see here is that in the countries where they have the most antibiotic consumption, there's a lot more carbapenem resistance of Klebsiella. Well, that probably means that if we continue prescribing as much antibiotics as we do, that we ultimately see the last effective antibiotic and staring out of our way within a couple of years or maybe decades. We'll have no antibiotics to treat simple infections with, unless we start to treat as narrow spectrum as possible and for a short duration as possible. So that means that we as clinicians should not prescribe antibiotics to patients that do not benefit of our antibiotics. For instance, people that have a viral infection, COVID-19, for instance. So what should we cover then? Well, the most likely pathogen is Staphylococcus aureus, another gram-positive cocci. And that leads me to the allegory of the head of the cobra, the head of the snake with its fangs and poison represents Staphylococcus aureus and streptococci. And the tail then represents gram-negative rods, anaerobes, and coagulase negative staphylococci. And if you then have a therapy directed at the head of the snake, you're then left with an innocent tail that you don't need treatment for. Well, is that paradigm true for all diabetic foot infections? Well, it's probably true in mild infections. We think that you only need to cover Staph aureus and streptococci, but we don't have any definite data yet. Maybe the prognosis is worse in case of polymicrobial flora. And we have to be cautious in case of severe infection and osteomyelitis because the stakes are higher. So it's more likely that a person can lose its leg or maybe even its eye. You also have to consider your local resistance pattern. For instance, we did a study in the Netherlands looking at the results of cultures of diabetic foot infections, and we found that only 85% of Staph aureus and 78% of gram-negative rods were susceptible to the, at the time, most frequently prescribed combination of antibiotics for diabetic foot infections, clindamycin and ciprofloxacin. So we switched from that empiric antibiotic therapy to another one that was more likely to cover Staph aureus. Okay, so what else do we do? Well, we have to look at the clinical severity of infection. If you look at an algorithm that was published in the guidelines, and I'll zoom into it, you can see that there's a difference between patients that have a mild and moderate infection versus those with a severe infection. Those with a severe infection are usually hospitalized, get IV fluids, usually go for surgery, and they probably need broad spectrum antibiotics. Or those with a mild and moderate infection, you can usually get away with narrow spectrum antibiotics. How do we define then infection severity? Well, the most important one is, I think, the International Working Group Diabetic Foot Infection Classification. That's almost the same as the Infectious Disease Society of America classification. Grade 1 is no infection. Grade 2 is localized to the skin with 2 or more signs and symptoms of inflammation, swelling, erythema, pain, warmth, pus. Grade 3 is more erythema or a deeper infection, an abscess, osteomyelitis, septic arthritis, or necrotizing soft tissue infection. And in the last update, we divided that group up into those with osteomyelitis and those without osteomyelitis, because we feel that patients with osteomyelitis need a different approach and probably have different outcomes than those without osteomyelitis. Here an example of toe osteomyelitis. And then infection grade 4 is every person with a sepsis, systemic inflammatory response syndrome combined with a foot infection, and SIRS is then defined as fever, under temperature, pulse, tachypnea, tachycardia, leukocytosis, leukopenia. And again, those persons were then divided into those with osteomyelitis and without osteomyelitis. You could argue that we could have picked one of the more modern definitions of sepsis, for instance, using the Q-SOFA score or MUSE, and so modified early warning signs. But we don't have a lot of data to support its use, so we stuck to CERTS. But maybe in the next update, we'll change to one of the more modern definitions of sepsis. Why do you do that? Well, partly because it predicts which persons are hospitalized and which persons will undergo an amputation. Now, what kind of empiric antibiotic therapy should we prescribe? Well, in case of mild infection, no recent antibiotic treatment in a temperate climate, you can stick to giving therapy for streptococci and Staph aureus. In the case of moderate to severe infection, if you live in a tropical or subtropical environment, if you've prescribed recent antibiotics, if you recently prescribed antibiotics, or in case of ischemia, then it's wise to also cover gram-negative pathogens and obligate anaerobes. And of course, in both cases, you have to reconsider based on the sensitivity report of the culture and based on clinical response. And these sensitivity results are hopefully then based on a deep tissue biopsy and not superficial swabs. Now, should you always cover Pseudomonas? Probably not, at least not in our climate zone, but you should consider it in case of tropical, subtropical climate. There's several studies that suggest that in Turkey, Tanzania, South Asia, Pseudomonas is a lot more common in diabetic foot infections, and in case you've already isolated Pseudomonas earlier. Should we treat orally or intravenously? Well, in case of severe infection, where you can't really be sure of the enteral absorption of antibiotics, and you want to make sure that you get adequate levels as fast as possible, because somebody is systemically unwell, your patient's systemically unwell, start with parenteral antibiotics first and then switch to oral therapy. There's clinical improvement. In case of mild infection and most of the moderate infections, you can usually get away with oral antibiotics. Now, there's hardly any proof for topical antibiotics, and it's advised not to prescribe those. Now, another speaker will talk to you about oral or intravenous therapy for osteomyelitis. I will not get into that, but you can probably switch from IV to oral therapy once the patient stabilized and has improved. So how about the evidence of efficacy, the agents that we use for diabetic foot infections? Well, as I mentioned earlier, you can give anything you want, except probably for tigecycline. That's not a preferred option because it's not as efficacious and it leads to more side effects. Now, another thing I'd like to discuss briefly is some bacteria seem to be in biofilm formation in diabetic foot infection, wounds, for instance, but also in osteomyelitis. And bacteria in biofilm tend to be less susceptible to antibiotics. Here's an example on the left, the graph, where you can see that the planktonic free-living Pseudomonas is susceptible to tobramycin, and once it's in a sessile phenotype in a biofilm, it's no longer susceptible to tobramycin. And on the right side of the screen, you can see the same thing for an antiseptic. And this is a very informative slide, I think, where you can see a droplet with Pseudomonas put on a flat surface, for instance, a table. After about 48 hours, there's a mature biofilm, and if you then lay a tablet of tobramycin, colistin, or ciprofloxacin into that droplet, you can see that it hardly has any effect or no effect at all on mature biofilm. But we don't know the consequences yet for the treatment of diabetic foot infection. I hope to find more studies in the update of the guidelines. So you can look at the risk of adverse events as well, including damage to the commensal flora. If you speak about damage to the commensal flora, the most important thing that I think of is C. diff. It's important to prevent C. diff in patients. But there are also other toxic side effects: skin, liver, acute kidney injury, and anaphylaxis. And in case of IV therapy, that can be central venous catheter complications, line infections, thrombosis. But as I mentioned earlier, intravenous therapy is probably not always required. Okay, what you can also look at is the likelihood of drug-drug interactions. For instance, trimethoprim and vitamin K antagonists, or rifampicin and virtually all the statins. You can look at drug availability. That's usually not a problem in our part of the world, but it can be in rural Africa. Financial cost can be a way to select for antibiotics. And that's probably about it. If you've covered all those questions, you usually select an appropriate antibiotic. So you could ask me thank you for your talk, but which antibiotics should I give them? Well, there are a couple of possibilities. These are just to name a few. For instance, flucloxacillin, which can be given to mild infection. It can be given orally. It's very cheap, but its intestinal absorption is not excellent, and it's not really predictable, and you only cover Staph aureus and streptococci. You could give clindamycin. The problem with clindamycin is that it doesn't cover all the Staph aureus and streptococci. You could give cephalexin, a first-generation cephalosporin, which has about the same coverage as flucloxacillin, but has a better intestinal absorption, but then also the Staph aureus have a slightly higher MRC, so that you need to cover for that. You could give amoxicillin and clavulanic acid. That is a therapy that you could give for severe infection. You could give that orally as well. You can have the same problems with oral absorption as with flucloxacillin. You could give piperacillin tazobactam, only IV. That will also cover Pseudomonas, but also anaerobes and some other gram-negative rods. You give moxifloxacin monotherapy, give it orally or parenterally. The combination of ciprofloxacin and clindamycin. You could give a carbapenem in case of ESBL. There's several options for MRSA, just to name a few: linezolid, daptomycin, vancomycin, but you could also add cotrimoxazole and piperacillin and tazobactam for Pseudomonas. I think what you should not do is to treat clinically uninfected wounds, because it has been proven in diabetic foot infections that it does not improve the outcomes, and the same is true for venous leg ulcers. We have to keep on reminding people to do that, and every new doctor has to be reminded that, a bit like Sisyphus rolling up his hill and then having it seen rolling back. So once again, my take-home messages are that infection is a clinical diagnosis, and I hope that after my talk you agree with me. And then if you want to prescribe appropriate empiric antibiotic treatment for diabetic foot infections, you have to know your local resistance profile. In case of mild infection, always cover Staph aureus and streptococci. Also in severe infection, you can probably get away with treating only Staph aureus and streptococci instead of mild infection, in case of mild infection. But if you have a moderate to severe infection, it's best to include gram-negative coverage, and sometimes, for instance, in case of ischemia, obligate anaerobes. Now, with that, I'd like to conclude my talk, and I'd like to point out that in May 2023, there will be the International Symposium on the Diabetic Foot. I'd like to welcome all of you. And with that, I'd like to thank you. Thank you for your attention. I'd like to hand over the floor back to the chair.